Welcome everyone. This is Dr. Manjulatha, consultant obstetrician and gynecologist, fertility specialist and laparoscopic surgeon.
Hello, myself Dr. Mamatha, consultant obstetrician and gynecologist, laparoscopic and infertility specialist.
So we are here today to discuss a critical topic in maternal health, which is hypertension in pregnancy. So we have Dr. Mamatha here who will brief us about hypertension in pregnancy, and it will be a mutual discussion so that you all benefit from that. So yeah, Dr. Mamatha, so can you explain what exactly is hypertension in pregnancy?
Yeah, certainly Dr. Manjulatha. So we all know what hypertension is. Hypertension is when the BP is fluctuating, like more than 140/90, right? So pregnancy also we have hypertension, and this in pregnancy we call it as hypertension when the BP is above 140/90. So hypertension in pregnancy doesn't mean that it's only one type, there are multiple different types of hypertension in pregnancy. So first thing is, let us talk about chronic hypertension. So chronic hypertension, when we say hypertension, as I said, BP is above 140/90 and it arises before conception. We see.
You mean to say 140/90?
140/90.
Limit
See,
is
the normal
140.
value of BP is, we know it's 120/80.
Correct.
So anything above that, and repeated reading comes the same way. And then there are certain other symptoms also which we'll brief you in further discussion.
So can you give a range, like approximate range on what should be the systolic and what should be the diastolic?
The normal systolic we say 120 to 130 is okay, and the diastolic always 80 or 90, less than 90 is always better. Yes. So anything above that, that is considering 140/90 is always high. So that's considered as hypertension. So in chronic, as I said, it arises even before conception. So the patient is already suffering from BP.
Right.
Okay. So in such patients, we should make sure that it is well under control and then further plan the treatment. And the other one is the gestational hypertension. So when we say gestational hypertension, it is during pregnancy. So during pregnancy means like about 20 weeks. So most of the patient presented after 5 months of pregnancy, or what we say is 20 weeks of pregnancy.
So you mean to say till 20 weeks the blood pressure will be in normal range.
Yes.
After 20 weeks
right,
it increases.
Right. So if it is, if we diagnose the BP at the stage of 12 weeks or 3rd month, then we call it as a chronic hypertension. We can't term it as a gestational hypertension.
It was there since before, but probably not identified.
So in India especially, we know our patients come only after 2 months. It's not that they come early.
That's right. For many of them, pregnancy is the first time they've even seen a doctor.
Yes. So in such situations, we diagnose early. That means the patient could have had BP before.
Right.
So after 20 weeks, we usually consider as gestational hypertension. And the next thing is something called as preeclampsia. Here, along with the elevated BP, we see other factors like the urine protein, and there are certain changes in the blood also. And this other one is preeclampsia. Here in preeclampsia, what happens along with the BP, there are other factors where the protein is increased in the urine, and the blood parameters, what we check, like the liver function test or renal function test, all this can be deranged. So, and the severe of this, that is, if it is associated with, along with all these preeclamptic symptoms, if there is something associated like seizures or convulsions, that we call it as an eclampsia, and which is very severe. That's when we need a different management, totally different. So each of this is not we can't treat them as the same. Each one will have a different kind of treatment.
Right. So that's a very clear overview. So I think what you mean to say is preeclampsia is protein in urine.
Yes.
Then we categorize it as preeclampsia mainly, and fits in pregnancy. Right. Along with hypertension is more probably.
Along with hypertension and the protein and other parameters also.
We'll consider it as eclampsia. Right. Yes. That was a very clear overview, Dr. Mamatha. And I think what we have when there is hypertension in pregnancy, the demand for the fetus is increases exponentially.
Right.
Like the blood supply, the demand increases exponentially as the pressure of the blood vessels is very high. True. So I think to handle this pressure is a little bit difficult. And that is where that extra attention is required.
Yes. So and here, like, see, both mother and child both are in danger. Right. We have to look after both of them.
Correct.
So and then probably, as you said, the placenta is included. The placenta is the one which is giving the blood or the nutrition for the baby.
Okay. So if we can divide it as maternal, placental, and fetal complications. So the maternal could be stroke,
Yes.
kidney issues, liver function
Liver
tests
function,
can be
yes,
deranged.
yes.
Patient can have eclampsia, that is fits.
And the liver, when you say it is jaundice. Jaundice is one
Jaundice,
thing which is the first thing
and
which
unfortunately
comes
it
up.
doesn't give us even enough time to act. It's that swift the
Right,
complications
right,
are.
right.
And placental abruption can happen.
Right.
There is premature separation of the placenta.
Correct.
So immediately the blood supply from the mother to the fetus reduces. In fact, it abruptly stops, and we can even lose the baby in that scenario. So
correct.
it's that important.
Important,
Right. And in the fetal complications,
See, the growth of the baby can be restricted, right? So what happens once the mother starts developing hypertension, there is some issue where the blood circulation is not enough, as you explained.
Right, correct.
So automatically the baby is under pressure. So the growth can be restricted, or as you said, sudden death of the baby is one thing what we are concerned about. So we always advise the patients to get detailed examination, like ultrasounds, which includes Doppler and everything, Doppler studies.
And I think that is when even patient gets very anxious, like why so many scans,
Right.
why so many scans. But we know what are the complications involved and why often scans are needed, blood tests
Correct,
are needed, because so that the success rate is better. So I think if we explain this to the patient and the attenders, they can better cooperate.
Yes.
with
And
us.
but see, when we say hypertension, it is not that all the patients will have hypertension, But at the same time, it's not that one particular patient will not have hypertension. So patient might look normal throughout
Right.
the pregnancy.
Exactly.
All of a sudden, the BP shoots up.
Exactly.
So that can happen. So this is not predictable.
Correct.
So, but there are certain high-risk females whom we can say that they are going to be under risk for hypertension.
Correct. See, this particular thing what you said reminds me of heart attack.
Right.
Now, when we see a patient who's absolutely normal, who's sitting, who's eating with us, and they rush the patient to the hospital saying,
Suddenly they
no
collapsed.
bantu and they collapsed.
Correct.
And there, when we see the BP is high, everything is high. So BP is like a silent killer.
Yes.
It can just manifest anytime.
Yeah, that is what. So that's why during pregnancy, when we say you have to come for a checkup, you have to come. I think most of us as gynecologists, we explain the patient what are the symptoms and everything. They should keep a watch, don't neglect it, and come to us.
Right.
That's very
always
important.
Pregnancy means patients expect happy ending.
Yes.
So it is not the case always.
Right.
So there are so many complications that we should know, and we are in a situation where we should explain the complications as well as not scare them.
Right.
That's
so it's a very
actually
difficult
challenging.
task. I know.
So going forward, we will also talk about the case scenarios which both of us have undergone and how we have treated them also.
Yes.
So Dr. Mamatha, in whom do you think the risk of hypertension in pregnancy is more?
Yeah. See, as I said, we cannot tell that this patient is going to get hypertension. Okay. So anybody during pregnancy can be very smooth if nothing happens. So that is a thing what we have to remember. But pregnancy also can be a risk. So anytime during pregnancy we can develop all these symptoms. So but there are certain ladies who have to be more cautious about these. We term it as high risk pregnancies, where the patient is above 35 years, elderlies.
Okay.
So if they've gone any treatment for IVF and conceived because of treatment, or like if they have family history of hypertension, or the lifestyle is very bad, before conception they'll be smoking, they'll be they'll be consuming alcohol, or like there's no exercise during pregnancy as well as prior pregnancy, so automatically obesity. Right. So obesity and all these things can be high risk for hypertension.
Okay.
So and there are other conditions also like lupus and everything where they can develop
the chronic conditions.
Yes.
Right.
But many times these things are not diagnosed prior pregnancy. So most of the time the patient, once they conceive, that is when we get to diagnose certain autoimmune conditions.
Correct.
So that is when we diagnose. So without any reason, there is either fluctuation of BP or the patient comes with thyroid issues. Then yes,
so
we
they
have
can
to
present with high blood pressure, and when you go back and find out why this high blood pressure, they might be having some pre-existing
disease. Yes. Yeah. So these are few of the patients who are under high risk.
Right. So if you can quickly give the audience an overview on the symptoms.
See, symptoms, what we have seen in our practice, many of them come without symptoms, they just come with asymptomatic, what we call. They just come saying that like their legs are swollen up. And these people, they consider swelling of legs as normal. I agree, it is normal, in most of the pregnancies, but because of pregnancy as it progresses, it can be normal.
Correct.
But then we can't neglect.
Right.
So swelling of legs could be other issues like your BP and everything. So, but some symptoms which the patient has to remember is headache, blurring of vision, or like they have difficulty in breathing, or all of a sudden one day they see they are puffed up, their face is swollen, the hands are swollen, the legs are swollen. But for these symptoms to diagnose, they should be aware of it. Okay, so along with this, so come to the checkup, come to the hospital. We will see, we have to check the BP. Once you come to the hospital, we make sure we check the BP, and we have to check their urine protein and other blood parameters like liver function, etc.
Elaborate, as you said, the symptoms could be headache, excessive vomiting or sudden onset of vomiting,
abdominal pain.
Right, abdominal pain, mainly upper abdominal pain,
yes.
And then breathing difficulty, facial puffiness,
and
sudden swelling
also.
of
Sudden bleeding can also be one of the
swelling of legs.
Yes.
These are the things which they have to be cautious about. Right.
And when you see certain symptoms, I think the family members have to be aware of this more than the patient, because many times the elders at home, they say we can monitor.
Correct.
This is normal.
Exactly.
So it is not normal. It
and
can
I think
be normal.
that happens with swelling. It is
yes.
either there will be family members who say it is normal,
they say
or
rest
people
madu kadme agutte.
Correct. Or people who say, oh, something has happened. So I think better leave the judgment to the
doctors, yes.
And we will examine if there is no protein in the urine, the blood pressure is normal. Yes, then it is a pregnancy related swelling, which is nothing to worry.
But you have to be cautious. You have to monitor. See, presently it is normal, but after 1 week they might present with something else. Right?
And so also we have the grading in edema. Edema means swelling of the legs.
Yes.
The grading probably we will discuss some other time.
Yes.
The edema can go up to the abdomen and include the face. So that we will talk about some other day.
So when you come to the doctor, when the patient comes to the doctor, we advise them to do the test, and I think they have to follow.
Right.
Okay. So many times
complaints.
We write down everything, but somewhere down the thing they don't want to. Monne tane scan ಮಾಡಿಸಿದ್ವಿ, ಮೊನ್ನೆ ತಾನೇ blood test ಮಾಡಿಸಿದ್ವಿ. Why do we need to do it again?
Correct.
This is what they think, and they don't go and they don't come back unless they come back with a complication.
Correct.
So we need to see the scan to check the Doppler, to check the fetus.
Actually, in this course of explaining the blood test, sometimes patients even end up saying that ಈ ಡಾಕ್ಟರ್ ಹತ್ರ ಹೋದ್ರೆ ಬರೀ blood test
ಮಾಡಿಸ್ತಾರೆ.
But what is involved in that we know.
Yeah. So, that's why, but I think most of us explain it to them.
Correct.
So, but when we explain it to them, understanding and following the orders is important.
Yeah,
so
that's one thing we expect from the patient
as well as the husbands and attenders, whoever is come, because many times they are the ones who say ಏನಾಗಲ್ಲ ಬಿಡು, they say. So that is one thing you people should neglect. Avoid doing it.
Correct. Yeah, so now that was a brief about symptoms. Yes. Now coming to the treatment, first thing I would like to emphasize as a fertility specialist is when you have undergone fertility treatment or you're planning pregnancy, I think you come for a preconceptional counseling, get everything checked. We have certain blood tests that we do. We check your height, weight, blood pressure. If it is required that you have to lose weight and then conceive, it is all right. 2 to 3 months, take a diet counseling, lose weight, and then you conceive. Or if your lifestyle is bad, say smoking, alcohol, you can stop everything, have a healthy diet. 3 to 6 months time, it can always be planned to prevent such life-threatening complications which comes because of this during pregnancy. So going to the management, so what we think, I think mild hypertension, lifestyle modifications, reducing salt intake, doing some amount of breathing exercise and walking should do.
Yes. And intake of water also. Consumption of water, hydration is very important.
Right.
And healthy eating habits.
Healthy eating habits. And walk, not sleep immediately after food. And when it comes to drugs, I think the first line medicines preferred are either labetalol or nifedipine is the second drug. So any variations in that thought from your experience, what do you start?
Labetalol is the main thing which I start. Earlier I think we used to give methyl dopa, which is not available now. We stick on to labetalol, which is good enough.
Good amount of results.
So we give that, but again now the problem with the patients is they have BP apparatus at home.
Correct.
Digital monitoring.
So I prefer that too.
Yes, we advise them to monitor at home.
Exactly.
But they take their own decisions. When the BP is slightly under control, they stop the medication.
And they try reducing the dosage. That's very dangerous.
That we should not allow them to do that.
Right.
Monitoring is okay. Monitoring, once they feel that even with the medication they are not able to control it, they have to immediately visit.
That is why what I tell them is check the BP, take the picture of that apparatus and send, rather than writing and sending. So that's what.
Yeah. So as you said about the treatment, I think we should talk about the eclampsia part. Eclampsia is what I said, along with seizures.
Correct.
So if a patient comes directly to the hospital, so she was completely controlled and everything, and they come back as an emergency saying that she threw convulsions. And she comes to hospital. So usually what we do is we start certain IV antihypertensives and something called as magnesium sulfate, so which is going to control the seizures.
Right, as a drip.
As a drip, yes, as a drip, IV drip what we give. And what I would say is, see, whenever the patient comes like this, the first thing is control her, save the mother. So
Correct.
Always we have to remember, when we say patient has come around like this, we are more concerned of the mother. Yes, we are concerned about the baby, but first saving the mother is very important. So we concentrate more on the mother, and then side by side, yes, we do for the baby also. So as I said, when we start this magnesium sulfate or any antihypertensive drips, it has other complications related to the drug also. The
drip itself can cause
the medicine itself can cause certain complications. So we have to monitor the urine output, or like monitor the reflexes of the patient, and then respiration has to be monitored. So when we monitor all these things, if at all during this phase we see there is something wrong, something abnormal happening.
So one thing I want to emphasize in what you are saying is, here is where team effort is also very important.
So team effort is very important in this.
Correct.
So when we say team effort, it is not just the gynecologist. We need a good pediatrician, because if the baby is preterm or if the baby is already compromised, so we need a good pediatrician. Along with that, I think we'll need more gynecologists along with us.
Correct.
That's very important. There's nothing wrong in taking help.
Right.
So probably when we are doing it alone, if we have one or two extra hands, it's much helpful.
Correct. So that is why we have made it in such a way that 24 hours there is a gynecologist cover, so that the respective charts, magnesium sulfate chart, labetalol chart, all of this is maintained, so that we know when exactly we should stop.
Right.
So what is that one symptom when you say, okay, stop magnesium sulfate?
So see, if at all the urine output, as I said, we have to monitor the urine output.
Correct.
So for this we catheterize. That's catheterize in the sense we put the tube. So for the patients to know, so
that you can accurately measure how much
the urine
output
is
coming
So
out.
when this urine output we see it's not up to date, it's not we are not getting enough.
Right.
See, normally we expect at least 30 to 50 ml per hour. So if it is going beyond less than that, especially 35 ml is a good amount, but if it is going less than that, then we are alarmed.
So you mean to say magnesium sulfate by itself can take a toll on the patient's
health, So when we say this patient comes with eclampsia, it is not just the management. Management also has its own risk. So I think explanation to the patient is very important. Patient attendance is very important, because sometimes there can be other complications which are related to the treatment also. So, but we can't stop the treatment, right?
Correct.
We have to save the patient as well as the baby. So it has to be taken. We take the risk and we manage.
Right.
Okay. And even after doing all these things, there are certain patients who have other severe complications, serious complications. And again, when we say teamwork, we need ICU management, intensive care management. So what about that, madam?
Yeah. See, when it comes to, as you said, intense complications, one of that which we miss talking about is something called HELP syndrome. So HELP syndrome is basically HELLP. H for hemolysis, EL for elevated liver enzymes, and LP again for low platelets. So hemolysis, in the sense, the patient can have internal bleeding. She can just start bleeding from everywhere, like gum bleeding, nose bleeding, urine, there can be hematuria. First thing what happens in hemolysis is there can be blood tinged urine. If we miss that, then you land up in elevated liver enzymes and low platelets, beyond which it becomes almost impossible to save the women. So this identifying HELP syndrome early is very important, and in this scenarios, blood products are very important. You give FFP, which is called fresh frozen plasma, and single donor platelet, which is very difficult to arrange, but the sooner it is arranged, the more chances that we can save the patient. So I think
when we get a patient of such kind of eclampsia or something, I think we have to keep a backup.
Correct.
We have to arrange
Already
the products
arrange
already.
and-
It's okay if we
Right.
lose it,
Right.
but then it's better to keep it ready.
Correct. And sometimes there is a very rapidly progressing help
Correct.
as well, where it doesn't give time to act. You see, because of hemolysis, the bilirubin increases. So what happens in hemolysis is breakdown of blood products, which in turn increases an enzyme in the liver called bilirubin. And when bilirubin increases, jaundice. So when jaundice happens, and by the time we recognize it, I think I can say there are hardly any minutes
To save
the patient.
Yes.
So it technically becomes impossible to save the patient. It is literally like, as I quoted an example of heart attack.
Correct.
That day. Heart attack happens, it blocks the major blood vessel, that's it. You do
It's very
anything.
difficult to save, yes.
And with such good ICU backup also, despite all the efforts, it becomes extremely difficult to save the women. And such unfortunate incidents have happened sometimes.
So sometimes what happens, like I don't know if you have seen it, but we discharge the patient, they come back with complications.
Correct.
So why don't you tell us about that?
Yeah, so see, these are accelerated hypertension which happens whenever there is gestational hypertension. It takes minimum of 6 to 8 weeks for the blood pressures to come to normal and the effect of pregnancy on the blood pressure to reduce.
Correct.
So it is not that you discharge and everything is fine. 6 to 8 weeks the patient has to be kept in close monitoring. So what I do is I discharge them with a couple of medications. I ask them to monitor blood pressure and keep sending it. 1 week when I see that the blood pressure is stable, then I understand that what medicines I have given her is keeping the blood pressure in the normal range. Then I tell her, okay, check only once a day, it is enough. But till then I'm literally behind her. Have you checked? Have you checked? So it's that important.
So I think not just the obstetrician, but after delivery, the patient also should take a stand, so that when we say follow up after a week or after a month, they have to come back and show us once, right? And sometimes I think as a teamwork, we ask a physician also to put in there.
Exactly. Physician, intensivist, everybody. And just we had a very good discussion on hypertension. Well, I would like to know your experience. Have you had any maternal or neonatal mortalities in your practice? Mortality meaning, as we said, there can be mother's death or baby's death. When the patient has hypertension in pregnancy. So any experiences with that, or any, just it was almost about to happen and by God's grace, she was saved.
So there are multiple patients who come with we have seen such cases, but then touch wood, or by God's grace, till now everything is managed well. So probably, as I said, teamwork.
Correct.
So when we work as a team, I think identification early is very important. My patients are very sweet. They listen to what I say and they come back whenever I tell them to come back, and they follow the orders. So when they follow the orders, when they follow the doctor's advice, come back for a regular check, I think we can avoid this kind of mishaps.
Absolutely.
What about you, doctor?
Even I would like to say that by God's grace, the reasons why I have not had any maternal deaths so far in the last 15 years is, one, I would definitely say God's grace.
Yes.
Second, that instincts, we say, obstetrician instinct, that works with friends, family, as well as with patients. Like that call when you have to stop trying for normal delivery and when you should give C-section. And even if she's 34 weeks, there are patients whom I have delivered at 30 to 34 weeks, just because of reduced urine output. They might have cursed me that day, but today they are happy. So that's one thing. And I have been using the same ICU setup from the past 9 years, and they have cooperated so well that I have not had any maternal mortalities. No patient admitted under me or Dr. Mamatha has lost her life. I would say it's God's grace and that goodwill.
And also, I think the team effort. We have to thank the intensive people also, the ICU people also.
Exactly.
They have done a real good job.
Really. And I really hope this God's grace stays with us forever.
I know, as you mentioned, you said like you've done cesarean section for the patients, and but there are certain myths where patients think that any pregnancy patient who come with high BP will land up in C-section.
Correct.
So I don't think that is true. What do you think?
No, absolutely not true. And again, we cannot say that, okay, hypertension this much, C-section. Okay, hypertension this much, No.
Yes.
Absolutely, studies say, and even we have given a lot of trial to
Yes.
for normal delivery.
Yeah, we wait for the baby's
Correct.
condition, mother's condition,
Right.
unless and until there is some issue, like either baby's heartbeat is fluctuating or like there's some other conditions like meconium stain, what we say. That's
and
the
yeah,
baby passing
uncontrolled
stools.
hypertension.
Uncontrolled hypertension, and whatever you do, we need to save both of them or either one of them. That is
Correct.
when we take a decision for C-section.
Right.
So I don't think all the patients land up in C-section.
And again, if we notice anything of help,
Yes.
like there is reduced urine output or blood in urine, I think that is the time when we don't
have to-
want to
yes,
wait.
yes.
And irrespective of the gestation and baby's condition, we take up for
Because
C-section.
as we have studied, right? So any high BP, we have to terminate the pregnancy
Correct.
when it is not under
That's the
control.
treatment.
Yes,
That's
that's the
the
treatment.
treatment.
Delivering is the treatment. So
Right.
termination of the pregnancy is a must.
Right.
So that is how we take a decision, I guess, right? We're not going to one is as I think you viewers should understand that, right?
Correct.
So we're not going to do C-section for all the patients.
And as doctors and hospitals, I
We
think
don't
our
want to do it.
primary intention is to save the
Save
mother
the
and
mother and child.
child. And if we are taking a decision of C-section or blood transfusion, anything, it is only for the
For the
patient
patient's
and
sake,
not
right.
for any other
Correct.
benefits. Or if patients cooperate and attenders cooperate, I think we can give 100% results as always, like
As
how we
always.
have been
Right,
doing
right.
so far. So to wind up all this, can you give a few tips from preconception till delivery? What should be followed in
See,
pregnancy?
preconception, yes, of course, all these things are very important. Yeah? Preconception lifestyle is a must. So as we said, the water intake, hydration is a very important thing, and avoid smoking, alcohol.
Right.
You're planning pregnancy, stop all that.
Right.
Okay, improve your lifestyle,
Right.
do exercise.
Right.
Okay. So next thing is, yes, once you start your journey of pregnancy and you've started meeting the consultant, I think you have to follow the orders.
Right.
So come for regular checkups.
Right.
Take the tablets given, especially calcium, which is very important. Iron and calcium both, but calcium, yes, when we are talking about hypertension, for us calcium is more
Correct.
important, right?
Correct.
So follow the advice, and when we say you have to monitor in the house and review when anything abnormal, they have to.
Correct.
So, and I tell my patients also, see, most of the mothers during pregnancy, they are the best person to assess themselves, right? So
You mean to say
anything
the patient herself?
Patient herself,
Correct.
yes. Anything abnormal the patient faces, she knows there's something wrong.
Wrong.
So when you know there is something wrong, don't wait for your family members or your husband to tell you what to do.
Right.
They have to visit us and take the advice.
Right.
It's okay if everything is normal, it's well and good.
Correct.
Right? But they have to come. So regular checkups and maintaining lifestyle is the one thing what I would advise.
Right. So just to summarize the tips, so your preconceptional counseling, please come for preconception counseling. Keep yourself hydrated. No smoking, no drinking, no processed food. Reduce salt intake. Once you're pregnant, please attend the hospital and listen to your doctor and not to anybody else, and know your body. Knowing your body is very, very important. And have I missed out something? Take the medications in the
Medications
right
properly.
time and be aware of the warning signs, as in headache, drowsiness, giddiness, vomiting, upper abdominal pain,
Any vision change.
blurring of vision,
Yes.
any vision change. So these are the alarming signs that you have to be worried about. And if the scans and blood tests, your doctor says it is necessary, it is necessary. It is not for the doctors or the hospital's benefit, but for your own. So I think this would have helped our viewers. So let's both of us request you to subscribe to our YouTube channel. So we are encouraged to do more of such
videos, yes.
podcasts.
And I hope it's helped all of them. You know?
Yeah.
So at least they've got some idea about
Right.
what hypertension is.
So we wish to know on the comments on what are your opinions, so that anything has missed or you need anything in more detail, we'll definitely get back. So yeah, thank you, Dr. Mamatha.
Thank you so much, Dr.
for all the time. It was a nice conversation with
Same
you.
here. Thank you so much.
Yeah, we should do more podcasts
often, I
like
know.
this.